let's have a discussion on the fractures of the clavicle. Now, before we start with the trauma related to the clavicle or the fractures of the clavicle, it is important to have a slight discussion on anatomical perspective associated with this bone that already you are very much aware of. Like, it is the only horizontal long bone in the human body. Like, all the long bones are aligned vertically, and this is the exception. You are very much aware of this. Next, now this is the only long bone ossifying by intramembranous ossification. Now, just try to understand that majority of the long bones, almost all the other long bones, they ossify by enchondral ossification. You know, ossification process is actually of two types. One is enchondral and the other one is intramembranous. Alright. Now, enchondral ossification is responsible for ossifying all the other long bones except for clavicle. Now, if you want to know what exactly is enchondral ossification, it is like that this is the site which is about to get converted into the bone, then all the ingredients are going to be imported at that site. Alright, in the layman terminology, if you want to understand. While intramembranous ossification is that all the ingredients were already present at that site, it is just needed to get ossified. Alright, so that is the only difference in between. Otherwise, rest will remain the same. Next point is that it is the only long bone which is having two primary and one secondary ossification centers. Now, just try to understand what is the meaning of this term, two primary and one secondary ossification center. Now, all of you are aware of the fact that imagine this to be a long bone. Alright. Now, it has got a single primary ossification center which is responsible for making up the diaphysis of this long bone, and it has got two secondary ossification centers. So, these are the two secondary ossification centers at the terminal of this bone which are responsible for the epiphyseal area, and it is going to become a part of the joint surfaces. Alright. So, that is going to be the intra-articular region for that particular bone. So, almost all long bones in the human body are having this single primary ossification center but two secondary ossification centers. But here what the exception is, in cases of the fractures of the clavicle, that the clavicle is the only long bone which is having two primary ossification and a single secondary ossification center. Alright. Next, it is the only long bone which is having no medullary canal. This again is a peculiar feature related or pertaining to the clavicular bones. And then finally, we are going to talk about that where exactly these fractures are about to happen in case of clavicular fractures. Now, for example, imagine this to be a clavicular bone. Alright. This is the lateral end of the clavicle and this is the medial end of the clavicle. Now, if you divide this bone into three halves, this is the medial 1/3, this is the middle 1/3, and this one is the lateral 1/3. So, the most common site for the fractures to happen is at the junction of the medial 2/3 and the lateral 1/3. So, that is the most common site. So, this is what exactly is written over here, that the most common site is the junction of the medial 2/3 and the lateral 1/3 for all clavicular fractures to happen. Although it is based upon the trauma or the mechanism of injury or the position of the bone at the time of incident, that the fractures can happen anywhere, but that is the most common site. Then point number 2 is, imagine if the question is not asking about the junctions. Imagine if the question is asked in relation to that what is the most common region, what is the most common site where these fractures are bound to happen. Then in that case, you have to take it up as middle 1/3. Alright. So, if the language of the question, it all depends upon the language of the question. If the language of the question is that they are asking about the junctions, then it is medial 2/3 and lateral 1/3 the most common site. But if they are asking about that which region based upon the options, then in that case, it is the middle 1/3. Hope you have understood everything related to these fractures of the clavicle. Alright. Now, what is the reason for this same? You know, it is the muscular attachment. As you know, that in the middle part, this is the medial 2/3 part. Now, in this region, what you can very clearly see that it is the sternocleidomastoid muscle which are responsible for pulling this bone up, while the deltoid as well as the gravity is responsible for pulling the distal region of the bone down. And that is the reason for displacement at the fractures of the clavicle. Hope you have understood. Because you might be thinking that why this junction is in particularly affected by the fractures of the clavicle. The reason is because we are having the two sets of muscular attachment. One is the sternocleidomastoid muscle, which is responsible for pulling the fragment up, while the gravity as well as the deltoid muscles, they are responsible for pulling the fragment down. And these two forces, which are acting in a counteract fashion, are responsible for creating the fracture once it is subjected to injury. Alright. As far as the treatment of these fractures of clavicle is concerned, you have got two modes of the management. One is conservative method and the other one is surgical fixation. So first we are going to talk about what is conservative method. Conservative means non-surgical approach. That means without opening the fracture site, without fixing it, you are going to manage the bone or the fractures. Now, you know, clavicular fractures most commonly are managed without any surgery, just by conservative means, as you have seen over here by the application of figure of 8. This is the figure of 8 sling, or just by putting the arm into or immobilizing the arm into the elbow pouch. Alright, as you can very clearly see over here that you have applied a figure of 8 sling. This is the posterior view and this is the anterior view. This is how it looks like. And the second mode of conservative method is just to restrict the mobilization. That is by putting the limb into arm or the elbow pouch. Simple. Alright, so you are not fixing it. But what is the problem with this conservative method? Ultimately, what is going to happen? Imagine this is the bone and it got fractured over here in this region. Alright, after the fracture, there is going to be a displacement of some sort. So it will result in a displaced fracture. Like the proximal portion has moved up and the distal portion has moved down. So there is a displacement at the fracture site. Now, both of these two bony fragments are now displaced in relation to each other, and there will be a union in between these two fragments itself over a period of time. Now, these two fragments over a period of time will tend to unite, but this union is not going to be a proper union. That means there is going to be a change in the shape of the bone. There is going to be change in the algorithm, means overall the contour of the bone is going to be different. As a result of which, it will lead to a most common complication associated with the fractures of the clavicle, that is malunion. So malunion is considered to be the most common complication associated with the fractures of the clavicle. Now, hope you have understood everything related to this. You know, again, quickly, if we revise what we have talked about that the fractures of the clavicle, most common region we have talked about. Second is the most common method of the management. Now, the most common method of management is conservative. It is not a kind of the bone which requires surgical fixation, because there are several relative indications only in which you have to perform surgery. Alright. So what is the associated complication related to this management is the malunion, because in whatever displaced site the bone is kept, it has to unite in that region over a period of time. There will be a loss of contour, there will be a loss of anatomical integrity, there will be a loss of anatomical original shape of the bone, which will result in the malunion. And it will appear like a bump at the site of the fracture. It will appear like a prominence at the site of the fracture. Now, if somebody asks you that is there going to be any impairment of the shoulder movement associated with this malunion, all right, just try to understand, because every time if there is a fracture of the bone which has malunited, or if the fracture has gone into non-union, then there is a possible associated abnormality of the movement related to the joint next to that bone. But if this bone has gone into malunion, is it responsible for creating a functional impairment in the long run? So there is no functional impairment, or there is no loss of function, or there is no limitation of function in shoulder associated with these fractures of the clavicle. Alright, if at all it has gone into malunion, it is not going to affect the movement of the shoulder. So hope you have understood what exactly we were talking about related to this. Now comes the surgical fixation. Now, although it is highly unlikely that they are going to ask you that what are the indications where you have to perform this surgery, but one by one we are going to talk about that these indications, first of all, they are not absolute indications. They are just relative indications. Alright? Relative indications means that there is no absolute requirement of performing surgery in these indications. Alright? The patient is going to have benefit out of performing surgery. When you perform surgery on it, then there is going to be relative benefit as far as the complications are concerned, but these are not absolute indication. So what is the first absolute indication? Obviously we are talking about, it is the lateral clavicular fracture, it is the lateral clavicular fractures. Now what do you mean by this term lateral clavicular? Imagine this is the clavicular bone, and if we are having the fracture at the lateral end Now it renders the shoulder joint unstable. Alright, so lateral end of the clavicular fracture is one such indication. Second is the displacement of more than or equal to 2 centimeter. Imagine if this is the bone, and after getting fractured, there is a displacement of the sort of more than 2 centimeter, then there is also a possibility of these two fragments going into non-union. Alright, so although malunion is a common complication, but there is too much, if there is too much of the displacement, then obviously non-union will also become a complication because these two fragments will fail to unite. So it becomes a relative indication. Next, symptomatic non-union, the same thing, that the patient is having pain, patient is having limitation of movement, patient is having impairment of the activities just because of this non-union at the site of the fracture. Then associated neurovascular injury. Imagine if there is a brachial plexus injury, if there is a loss of the pulsations, if there is hematoma, that means collection of too much of the blood, so that you are subjecting or you are thinking that there could be an injury associated to the arteries, veins or nerves associated with this fracture of clavicle, which need to be observed. In that case, you have to open the fracture site. Alright, then open fractures, obviously, when the fracture is already open, why not to fix it in its proper way? And finally, unstable or the floating shoulder. Now we are going to talk about this floating shoulder later, but at this point of time you came to know what the relative indications are. Highly unlikely, because this is considered to be a secondary question, highly unlikely to be asked in this postgraduate examination, but you should be aware of this fact. Next, how these surgical fixations are carried out. You are having a pre-contoured plate. Now just have a look at this image. Now here you are having a clavicular fracture in the mid 1/3 region, alright, and it is being fixed in its anatomical inclination by placement of the pre-contoured clavicular plate, but with the use of, now this technique is open reduction internal fixation. Simple, that you have opened the fracture site, you have reduced it using the clamps, and then you have performed the fixation with the pre-contoured locking plate. So this is how it is being managed. So hope everything is clear related to the clavicular fracture as far as questions are concerned or the examiner is concerned. Examiner wants you to understand why malunion, what is the most common site where the fractures are happening. Alright. Next, now all of the components or all are the components of the floating shoulder except. Alright. Now here we are having a question that they are asking about a floating shoulder. Now there are 3 points related to this topic. Point number 1. That this is the one question which we are expecting is going to be asked in your examination in your near future. Point number 2, this is for the first time. If they ask this question, this will be the first time they will ask this question. And point number 3, that already we have talked about that it is a instable or unstable kind of the fracture which will result in the requirement of surgical fixations. Alright. Now what are the 3 components of the floating shoulders? Now if you look at this image, alright, just concentrate on this image. Now here we are having a complete fracture of the clavicle. Complete fracture. Second, we are having a complete fracture of the glenoid. So these are the 2 absolute components of this floating shoulder. Now associated with this fractures, there could be an associated injury to the, or there could be injury to this ligaments also. Like we are having coracoacromial ligament. Alright. Or there could be a possibility of injury to the glenohumeral ligament. So although these 2 are not the component of the definition, these 2, that means glenohumeral ligament injury or coracoacromial ligament injury, both of them are not the component of the definition. But in order to have the completion of the options which are provided, it is going to be kept in your option. Now back to the question. Now all of the following are the components of the floating shoulder. Here we are having the fractures of the clavicle, which is yes a component. Second, the fracture of the glenoid, or instead of writing the fracture of glenoid, they can give you the fracture of scapula because glenoid is the region of scapula itself. Third is the fractured neck of humerus. Now we are not having this as a component in the definition. You look at this. The humerus is all normal, alright, or it is not the requirement that there has to be a fracture in the humerus in the proximal region to be called it as a floating shoulder. Now, first of all, try to understand what do you mean by the term floating shoulder? Why is it kept floating? Because the clavicle, one is clavicle and the other one is scapula, are the 2 bones. The entire assembly of shoulder is connected to the axial skeleton. So these are the 2 bones. One is clavicle, other one is scapula, through which the entire assembly of the shoulder joint is connected to the axial skeleton. If there is a fracture or the breakdown in this one clavicle and the second one in the glenoid,